everyone on this Friday. I know it's different times. Good morning, good evening, good afternoon, good night, whatever it may be in your time. So first of all, I want to thank all those who are joining this session. I can tell you this is going to be a great session. But before we start, I want to thank a few people. I particularly want to thank Dr. Batra, Anjan Batra, my friend, who did the last program last month while I was away, dealing with some family illness. So greatly thankful and grateful to Anjan for doing that. So today's program is going to be presented from India again, Dr. Sai Kiran and Dr. Mukund. Dr. Sai Kiran is from Trivandrum and Dr. Mukund is from Manipal. They are going to be presenting an interesting case, and our experts, designated experts, I should say, are going to be Dr. Batra and Dr. Escudero, Carolina Escudero. Both of them have been in prior programs and may be familiar to all of you. Also want to thank all these people who have endorsed our program, including Children's HeartLink. Bistra Zaleva is joining us today. Heart University, OHSU, which is my university, PACES of the Pediatric Congenital and Electrophysiology Society. And again, thanks to a lot of people from PACES, such as Susan Etheridge. I think Tony McCanta is here. I haven't been looking at the list of participants for a few minutes, so I'm sure there are many more here and will also join. And Project ECHO, which does not stand for echocardiogram, but stands for Extension for Community Health Outcomes, based out of University of New Mexico, for their support. And then our financial sponsors, Boston Scientific and Medtronic, for their generous sponsorship. So with that, we will go ahead and get started. And Dr. Sai Kiran Karla from Trivandrum will share his presentation, I hope. Go ahead and try to share, Sai Kiran. And you can start talking whenever you're ready. You're muted, by the way.
Yes, sir. Thanks for the opportunity.
Of course, of course.
My slides, sir?
Yeah, we can see it. Just go to a slideshow view because right now we are seeing it. Yeah, beautiful. Go ahead.
Good evening, everyone. I'm presenting a case of interesting case of tachycardia in a newborn. Coming to clinical details, day 0 baby girl weighing 3.6 kgs, born out of normal vaginal delivery, noted to have apnea at birth. She was resuscitated and intubated. Cyanosis was seen at day 0 of life, around 60%. She was not in heart failure. Referred to our institute for further management. She was born with. She was transported with prostaglandin infusion. On arrival at our department, we have done a screening echo, and it was showing Epstein's anomaly with moderate to severe AR, small ostium secundum ASD shunting right to left with functional pulmonary atresia, severe PH. Go score is around 0.81. This echo clipping image, you can see there is a plastered
You go back one slide.
Yes, sir.
So some of the audience, I'm sure there are lots of pediatric cardiologists in the audience who know this already. But can you talk a little bit about the GOS score? Is 0.8 a good score or a bad score?
GO score is used to calculate the outcome of neonatal Epstein. So, like we use the atrialized right ventricle, and right ventricle and left ventricle and left atrium. Together we calculate the score. Score more than 1 is a poor prognostic value, and score less than 1 is a good prognostic sign.
Excellent. Okay, please go ahead.
And on day 2 of life, child was noted to have faster heart rates during hospital admission. And this was the ECG taken during the tachycardia. Shall I go ahead?
No. Just to hold on here. Hold on. Let's have the experts weigh in on this ECG. Carolina, you go first, please.
Sure. So with this ECG, you can see that there is a narrow complex regular tachycardia. And then trying to determine what your possible tachycardia mechanism is, you can see that immediately after the QRS that there is a sharp deflection in the ST segment, which looks like it is negative in the inferior leads. And so this looks like this may be consistent with a AV reentrant tachycardia.
Anything else you want to add, Anjan?
You know, I think it's a great EKG because I agree, first of all, yes, definitely a narrow complex tachycardia. But when we're looking at the ST segment, boy, I would almost call those retrograde P waves. And if you look at lead 2, first of all, you don't see P waves before the QRS. And then you see what looks like a P wave after, right after the QRS, and it's negative, right? So typically the best lead to look for P waves is lead 2. And P waves should be upright. And in Epstein's in particular, where you have a huge right atrium, you would expect the P waves to be large, huge P waves, right? So you don't see upright P waves. I think everybody can agree with that. And the question is this a retrograde P wave or is it a part of the T wave that we are looking at the negative deflection? And I think looking at the narrow complex tachycardia rate of about 280 beats a minute, I would say this is most likely to be a retrograde P wave. And these are peaked retrograde P waves because the right atrium is so enlarged.
So, electrophysiologists, so one of the objectives of this program is to help non-electrophysiologists get an insight into how electrophysiologists think, right? So we divide these tachycardias into short RP and long RP. So what you're saying is this is a short RP tachycardia, right?
Correct.
So what are the differential diagnoses that we typically think of when we have a short RP tachycardia? Carolina, I'll let you go.
Yeah, the other thing I just wanted to point out before going into that is that if you look in V2 and V3 as well, you can see that's, as was pointed out, this very sharp negative deflection. So certainly wouldn't be consistent with a T wave. And so also suggestive of those retrograde P waves. So for a short RP tachycardia, things that we would typically think of would be an AV reentrant tachycardia or AV reciprocating tachycardia, so related to an accessory pathway. And we would think about AV nodal reentrant tachycardia. And you could also think about a atrial tachycardia, but with a long PR interval. So then that gives you that short RP.
Fantastic. So there's a question from Dr. Deepa. Is the deflection seen in the ST segment in lead 3 the P wave? So yeah,
I was going to say, Balaji, in medicine, there is, you use your best judgment. You can never hang your hat for 100% on saying, oh, I know for sure it's a P wave. I know for sure it's a T wave. You go with your best educated guess and say, this is your differential diagnosis. And to answer your question, there is a high likelihood that the answer is yes, but can we be 100% sure? No, we don't have to be 100% sure. We have tools available to us that can help differentiate as we move along with the case.
Great. Yeah, but also I would add to what you're saying and say a lot of the ECG diagnosis comes from experience and seeing lots of ECGs and pattern recognition, right? So this sharp wave right after the QRS complex, I mean, how many of us have seen such a sharp, discrete T wave? T waves don't look like this typically. They're much more broad and blunt. So when you see a sharp little wave like this, the chances that this is a P wave go up enormously. Then there is a question about, can this be PJRT? And the answer is no, but I will let you experts say why it's not PJRT.
So PJRT is typically a long RP tachycardia. So it's also an AV reentrant tachycardia related to an accessory pathway, but the accessory pathway conducts with decremental conduction. So it takes a long time for that activation to go from the ventricle back to the atrium. So that gives you a long RP interval. So that would be why I wouldn't call this one a PJRT.
Fantastic. Thank you. So what about just to be a little provocative? So we had AVRT and AVNRT. What about an atrial tachycardia or flutter? Why is this not flutter? Why is this not an atrial tachycardia? Or could it be one of those? Let me put it that way.
I have a very simple rule in medicine. When anytime somebody asks, can it be? The answer is always yes. It's not about can it be. The question is, what is the probability of it?
Very good.
And I think, because we'll be proven wrong if you just say for sure. I think just you have to look at the whole picture. You have to see what this patient has, what is anatomy, what is this kid at risk for, and given the fact that this is an Epstein's anomaly, you have a accessory pathway associated with it. So that's where the most likely etiology is. Having said that, can it be atrial flutter? It can be. I would rank it a little bit lower because it's a much slower rate for atrial flutter. Atrial flutter typically is a much faster rate. And usually you have 2-to-1 conduction. You have some variable AV conduction. And again, we have tools to help differentiate atrial flutter from AV reentry tachycardia that I don't want to get into because I'm sure it'll be coming up as we go on in the case.
Question from Peter Hessline. Peter, thanks for joining us. Very good to see you. Dr. Hessline is a very senior electrophysiologist, now retired, but still very active, especially in India. What about the P-wave axis? So, one of the things we can do is by looking at the morphology of the P waves and the directionality of the P waves, we may be able to make a guess as to where this accessory pathway could be, or where this atrial activation begins, I should say, And if we think this is an AV reentrant tachycardia, the point where it begins in the atrium is where the accessory pathway inserts into the atrium. So any thoughts on the P-wave axis and as a result, the location of this potential accessory pathway or the atrial depolarization, where does it start? Who wants to go? If nobody wants to go, I will ask Peter to say what he thinks.
I think Peter should take that one.
Okay, Peter, you're up.
All right. Well, yeah, I regret the senior denomination, but also, so I completely agree with the experts that these sharp deflections after the QRS are clearly P waves, and the direction of the P wave is curious because sharply positive in AVR, let's say, which means that these are pointing to the right, meaning that they are probably coming from the left. And knowing that this is an Epstein's and postulating that there's an accessory pathway, one would guess that this is most likely to be on the right side where the tricuspid valve is so odd. In this particular case, I would still say that considering this heart is mostly a large right-sided structure, that we could still have a right-sided pathway that is coming from an enormous tricuspid annulus, and that the left side is minuscule here. Nevertheless, I think it is a little curious that that this, one would normally say, well, golly, this is a left-sided pathway.
Thank you, Peter. And then before we move off from this ECG, there's a question from Dr. Varun. What about an atrial tachycardia with a long PR interval?
So that would be That would still be in your differential for the cause of tachycardia. But I think as Dr. Batra pointed out, we have to look at what's most likely. And the most likely in an Epstein's anomaly would be related to an accessory pathway, but certainly still having that as a potential differential, especially if you have atypical responses to some of your therapies or to some of your diagnostic maneuvers, I think is important.
Fantastic. Next slide, please. Sai Kiran. Okay, so we have our first question slide. And, based off of a lot of what we've discussed, again, we'll do the audience polling here. There's no right or wrong answer most of the time in our question and answers, so people can weigh in. And mostly the questions are there to promote discussion rather than, say something is right and something is wrong. So people can choose and submit. And okay, whenever you're ready, Hannah, please show us the results. 79% said orthodromic atrioventricular reentrant tachycardia. 12% said antidromic. A small percentage said AVNRT, and 3% said atrial flutter. So I think let me ask the experts to explain what's the difference between orthodromic and antidromic atrioventricular reentrant tachycardia and why this is not antidromic tachycardia. Carolina.
So orthodromic and atrioventricular reentrant tachycardia both involve a reentrant circuit using both your AV node and the accessory pathway. But the difference is the direction of conduction. So in orthodromic, with ortho meaning normal, your conduction is down your AV node, and then that's how you activate the ventricle, and then back up your accessory pathway to activate the atrium. Because you're going to be depolarizing your ventricle via the AV node and via your normal His-Purkinje system, this should be a narrow complex tachycardia unless there's another reason for having a wide complex, such as a rate-related or an intrinsic bundle branch block. In antidromic, meaning the opposite of normal, then you're going to be having conduction going down the accessory pathway to activate the ventricle and then back up the AV node to activate the atrium. Therefore, because you're depolarizing your ventricle through an accessory pathway, it's going to be a wide complex tachycardia.
Yeah, thank you so much. So antidromic tachycardia usually comes in the differential diagnosis of ventricular tachycardia or wide complex tachycardia. And I'm going to say something that might be considered somewhat insulting to some of the electrophysiologists and the knowledgeable people here, but there may be one or two people who haven't heard this before. One of the things I emphasize, particularly to residents, students, etc., is that there is only one way the QRS complex can be narrow. There are many ways it can be broad. If it's narrow, it means it's coming down the His-Purkinje system, and the His-Purkinje system is working fine. So whenever you see a narrow QRS, you immediately know it's coming to the ventricle through the His-Purkinje system and it is working fine. And so, as Dr. Escudero said, ortho means normal or usual, and dromic means direction. So orthodromic means it's coming to the ventricles in the usual direction. So based off of all this, the highest likelihood is that this is orthodromic atrioventricular reentrant tachycardia. Antidromic tachycardia is off the differential because it would be wide, and this is not a wide QRS. AVNRT, in one of the simple rules of thumb is that in AVNRT, the P waves hide inside the QRS complex. So usually, typically in what is called typical AVNRT, the P waves are hidden, they are hard to see, whereas in this case, we think we can see the P waves really well. So AVNRT would go down in the list of differentials. Atrial flutter, Dr. Batra already talked about. And sinus tachycardia would also be a differential for what electrophysiologists would call long RP tachycardia. So just like PJRT is out of the equation, sinus tachycardia is out of the equation because the P wave should be before the QRS in sinus and not after the QRS. Thank you. Let's go to the next slide. Okay, another question. What should be done next? stop the inotropes, do a vagal maneuver, do adenosine IV, do DC cardioversion, or do a transesophageal EP study. Again, there are no right or wrong answers. Sometimes there are multiple right answers. We'll give it a couple of seconds while people think about all these options. And I kind of, to be provocative, we made the question, what should be done next? Obviously, sometimes you do these things simultaneously. Okay, Hannah, we should be good. All right, fantastic. Most people opted for adenosine or vagal maneuvers. And I think maybe one person opted for DC cardioversion. Any thoughts on these options and why some things are right and some things are not? Okay, Anjan, why don't you do it?
Yeah, I think for starters, there's no wrong answer over here. I think what we are trying to see is which is how would you proceed from step 1 to step 5? If you're on inotropes and you don't necessarily inotropes are not helping you in a scenario like this. Vagal maneuvers and adenosine are both great choices, knowing very well that vagal maneuvers are the easiest thing to do, but they're at best maybe 50% effective. But you can make an argument there's very little harm in trying the vagal maneuvers. Adenosine, almost in my books, if it's reentry SVT with AV reentry tachycardia, it will work 100% of the time. Not 99% of the time, 100% of the time. The only reason it won't work is if you don't give it enough, if you don't give enough, or it kind of breaks briefly and goes right back into it. But you should see a change. And one golden rule of thumb I always says, if you're giving adenosine, please hook up a 12-lead EKG, because the information we get for the 2 beats when it breaks is the most valuable information in terms of treatment. And DC cardioversion will also work, but why use something more invasive or more, greater if you don't have to, if there are other tools available to you. And transesophageal EP study, it is basically you put the esophagus down, the probe down the esophagus, you overdrive pace and you break it, something like you do in the EP lab. Again, it will work, but you have so many other better modalities that why go to something like the transesophageal EP study.
Let's talk for a few minutes about adenosine. I think we talked about adenosine in one of our earlier sessions quite a few months ago, and we haven't talked about it for quite some time. You rightly said that adenosine should work about 100% of the time, at least briefly. Carolina, what other thoughts go through your mind whenever you're trying to give or advise somebody to give adenosine to a newborn like this?
So I think Dr. Batra said one of the important things. So that's also something that I tell people, that whenever you're going to give adenosine, definitely be running a rhythm strip at the very least, but preferably a 12-lead ECG, so we can get information from a diagnostic and potentially for a therapeutic point of view. With adenosine, so it's important to make sure that the administration is appropriate for adenosine. And so making sure that it is through an IV that's a large bore IV and more central, and making sure to give it as a push with a flush afterwards in order to make sure that the administration is appropriate. For the dose of adenosine, I would typically start at 0.1 and then can go up from there. And so those would be some of the major things with adenosine. When we hear that adenosine doesn't work, so my differential, especially in a tachycardia where I would have expected it to work, is either an administration issue with either the IV access or with how it was bolused and flushed, that it worked very briefly and then it recurred. So which would really, that's one of the reasons why getting that rhythm strip is helpful when you give adenosine, or that the tachycardia mechanism does not respond to adenosine.
I'd like to just make one point.
Yes, please.
Sorry to interrupt.
No, please, you're not interrupting. Go ahead.
This is an Epstein's patient with undoubtedly a pathway who likely has WPW. So if you're going to be giving adenosine, it would be great if you could have the ability to cardiovert, because there is a small chance you'd cause atrial fibrillation, which then could conduct antegrade and cause problems.
Yes, absolutely.
Very, very important point. Also, one other thing that I always emphasize when giving adenosine, Adenosine is quickly broken down by the RBCs or blood. So do not pull back on your syringe. When you've got your adenosine hooked up to your IV, don't pull blood back to see if the line is okay. Do that all beforehand with your flush syringe. Make sure the line is good, make sure it flushes well, maybe even draws back, etc. But do not pull blood back into your adenosine syringe. Give your adenosine really fast. Another question to the experts. Is there an upper dose of adenosine? I often get called and they say, oh, we gave 0.1 milligram per kilogram. We've given 0.2 milligram per kilogram. It hasn't worked. What should we do next?
I mean, we use really high doses of adenosine in the EP lab. So we keep, if we know that this is a AV reentry tachycardia and it's not getting the effect, we'll keep going higher and higher till, and I don't want to hang my hat on a higher number, but yes, we can go significantly higher than the 0.1 or 0.2 per kilo.
Great. Thank you. Also, it may be not quite relevant to this particular infant. I think the point that Susan made is the most important one. What other conditions, if the patient has certain conditions, would you be more cautious with adenosine, et cetera, et cetera? Any particular cautions that we need to be aware of when giving adenosine, and may not necessarily be relevant to a newborn, but even say older children? Okay. Please, those who are not speaking, please unmute. Please mute yourself. Thank you.
Sorry.
Okay. Sai Kiran, go please to the next slide. Yeah. So
Administered 100 micrograms per kg adenosine, and this was the rhythm strip taken during that administration. Any comments?
I love this because this is what happens in real life, right? You get a really crappy tracing, and you still have to make something out of it. So, any of the experts, tell us what you're seeing.
I think the tracing is not ideal with the amount of baseline artifact, but I think it still gives you some very good information. So you can see on the left-hand side that there was still that narrow complex tachycardia that we had. And then it looks like there was a sudden termination. You can see just right before that more significant upward deflection that it looks like there's a prolongation then in your R to R interval. So it looks like there was a sudden termination. And then what's very interesting is that then at the latter half of the rhythm strip, you see that the QRS morphology is very different. So now instead of that predominantly negative, you have a predominantly positive QRS. You can see that there are P waves. So it looks like sinus P waves beforehand. And then you can also see some slurring at the onset of that QRS.
Anything else? Anybody, any of the other electrophysiologists wants to emphasize?
One thing I would mention, and we talked about how that few beats right after you give the adenosine. And what happens is as soon as you terminate and the effect of adenosine is still on board, your AV node is shut down. And so your pre-excitation is at its maximum for those few beats. And that's why sometimes on normal, during a normal EKG that you get a baseline EKG, you may not see that pre-excitation as well as you would see for those 3 or 4 beats when it terminates. So I think you can see that over here where the last 4 beats are really pre-excited because your AV node is completely shut down at this point.
Great point. Great point. So one of the things that I do, and I'm sure most electrophysiologists emphasize to students and residents, is whenever you're dealing with a child with a supraventricular tachycardia, first of all, get a 12-lead ECG, like Sai Kiran did at the beginning. Then when you're giving the adenosine or when you're doing your vagal maneuver, run 12 a 12 lead rhythm strip. Now here we have a monitor strip. It'd be much more ideal to have all 12 leads running simultaneously while you do the intervention. And then after you've converted, get another 12 lead ECG. So if you should really have 3 sets of ECGs on these patients. Next slide, please, Sai Kiran. What does the change of axis mean here is a question that was asked. Go to the next slide. I think the next slide illustrates the change in axis really well and also explains why it happens. So this is a post-conversion ECG and makes a lot of the points that Dr. Escudero was making. I think we should elaborate on this. Please, Carolina, go ahead.
So this is a 12 lead ECG after termination of tachycardia. And so what you can see here is that there are now P waves before your QRSs. You can see that they're quite large, especially in lead 2, as we chatted. Lead 2 is one of the best ones to see your P waves. So you see these peaked P waves suggestive of right atrial enlargement. And then you see immediately afterwards that there is a broader QRS than we saw at baseline. And you see that some other features. So there's a very short or almost absent PR interval. You can see that there's initial slurring of the QRS. I think the slurring you can see nicely there in AVR and in V2. And so with the features of the short PR and the wide QRS and that delta wave, this would be diagnostic of ventricular preexcitation or overall WPW for this patient.
So why is WPW associated with QRS axis change?
So you're depolarizing the ventricle in a different way, so not through your usual His-Purkinje system, and so dependent on where that accessory pathway is, it can cause a change in axis.
Fantastic. And this is maybe for the more, the postgraduate students, if you will. Any thoughts on the location of the accessory pathway based off of this ECG? Anybody want to take it?
I'll take it.
Yeah, go ahead.
I'm about as postgraduate as you can get.
PGY 30, like me.
It's a left bundle. This is V1. It's a left bundle. So that suggests the pathways on the right side. The other important thing, and I think to remember, is in Epstein's, this is not what we expect. We expect, like, if you were thinking, oh, is this patient got WPW? Yes, because in Epstein's anomaly, we expect a right bundle or kind of high RV forces. So at least I would say this is a left-sided pathway. And this Q wave here in 3 probably, right-sided pathway. And this Q wave here in 3 makes me think maybe more septal. What do you guys think? So right-sided, as you'd expect, because there's a left bundle.
Anybody else? Any of the other people? There is actually a question from somebody. Will this QRS axis change be found both in orthodromic, antidromic AVRT and AVNRT, I think, or VNRT? Maybe Varun, you should retype your question because some of it is AVNRT. Okay. I think this is WPW. So AVNRT would be invoking a totally different mechanism and an abnormal AV node with dual AV nodal pathways, etc. So Occam's razor will tell us not to go there. If we have one explanation for this whole thing, why bring in a second explanation? So let's stick with an accessory pathway. And again, Mohsin says this is a right posterolateral accessory pathway. What do you think? Peter, what do you think? Where do you think this pathway is?
Well, definitely right-sided, which is again what one might not have predicted from the tachycardia EKG. I think it is, near the annulus somewhere. It seems to be pretty much isoelectric in AVF.
So for the non-electrophysiologists here, Peter, both you and Susan said this is obviously right-sided. to us electrophysiologists, we know why we say this is obviously right-sided. Why do you think, what are the thought processes that we have in our head that tell us this is obviously right side?
Well, again, in lead one, the QRS is definitely positive, so it's definitely heading from right to left. And I think that's probably the only lead that you need to sort that out.
Great, thank you. So, when we look at one and AVL, that one AVL and AVR tell us left, right. So if we see the QRS complex going from right to left, it should be positive in one and AVL and negative in AVR, which this obeys. And then you look at the precordial leads, V1 through V6, typically the right ventricles on the front and the left ventricles in the back. So it's going away from V1, and so it's going away from the right side. It's going towards the left side as seen by V6. So whenever we see a left bundle branch block type of morphology, we know this activation is coming from right to left, and vice versa. If you see a right bundle branch block type of morphology, typically comes from left to right. And then now the little quibbling that's going on is about 2, 3 and AVF. Right? 2, 3 and AVF tell us more inferior, craniocaudal directionality. Go ahead, Peter, sorry.
I said I might qualify what you said just a little bit, because in lead V1, the initial deflection is positive.
What I meant was the overall deflection is negative, but I agree the initial deflection is positive. So how much of your thinking goes to the initial deflection and how much goes to the overall deflection?
Well, the initial deflection makes me pause and think a little bit more. But the overall deflection is important. And if you look at V5 and V6, everything is headed toward the left in that direction, in those leads.
Thank you. So, the initial deflection, if the initial deflection was negative, that would tell us it's right on the anterior aspect of the right side. So the fact that it's not, there is a little positivity in the beginning, means it's probably not right anterior or right anterolateral. And I think that's why Mohsin is saying this may be right posterolateral. Would people agree with that? By the way, Mohsin is an electrophysiologist from Pakistan. Anyone else before we move on? Is localization important? I know we make a lot of it in EP, but to the non-electrophysiologists, this is important. Carolina.
I think not as important to the non-electrophysiologists. I think we do make a lot of it. I think especially in neonates and in children with congenital heart disease, I think we can tell about laterality in many cases, but being more specific than that, I think is challenging. More specific and accurate.
Thank you. Thanks for saying that. Okay, next slide, please.
Can I add a point here?
Yes, please, of course.
Whatever is all correct, negative deflection predominant in V1 suggestive of LB morphology, left bundle branch block morphology, and a point like transition precordial, it's like early transition or late transition, basing on that. Before V3 transmit is nearer to the septum. If it transits after V3, that S2R transition, if it comes up in V4, V5, it points towards more free wall located. And here I can see right side, and 2-3 AVF is negative. It is more of posterior or inferior, and it is transiting in V2. So I would like to put as right posterolateral, posterior septal pathway.
Posteroseptal, okay.
Apology, may I make one?
Yeah, please, Peter, go ahead. Just go ahead.
Just to make this a little bit more interesting, considering the difference between the proposed location of the pathway during tachycardia as opposed to what we see here, perhaps there's more than one pathway.
Well, you often see that in Epstein's, right?
It's not unusual.
So, and also we sometimes see in Epstein's there may be one antegradally conducting pathway and another a pathway that's just totally concealed. It's purely retrogradely conducting pathway. So yeah, we definitely have to keep that in mind. I think the point that Sai Kiran makes is a great one. So the in V1 through V5, the transition from a purely negative to a purely positive probably doesn't even happen till like V5. V3 and V4 are like, positive and negative sort of cancel each other out. So it's a pretty late transition, which puts it more right-sided than closer to the septum. So that's the only thing, Sai Kiran, which makes me think this, I agree with you, 3 and AVF are negative, 2 is positive, which puts it more inferior or posterior, as electrophysiologists like to call it. But this very late transition makes it unlikely to be anything septal.
I worry that we rely a lot on these algorithms that are published in people with normal hearts too.
Yeah.
And the
Yeah.
child doesn't have a normal heart. So Carolina's going to answer that question in a paper she's working on. So.
And also this is an infant, and most of those, of course, are
Yeah.
in adults, all of them.
So there's a question from the audience, from Dr. Rajesh Vishwanathan. Are there any accessory pathways resistant to treatment, and can it be useful from a prognosis point of view? I guess the operative word is treatment. What do you mean by treatment? My answer would be no, not particularly. I don't think location necessarily gives us a lot of information about how difficult an accessory pathway is going to be in order to treat it. Obviously, multiple accessory pathways would be harder to treat. Those patients often have more complicated arrhythmias. Sometimes they can even have, we talked about orthodromic and antidromic. They can have what we call duodromic. So going down one accessory pathway, going up another accessory pathway, etc. So things can get very, very interesting and complicated in multiple pathways. But other than that, probably location per se does not correlate with how am I being a little overly confident? Okay, I will take that as agreement. Let's go to the next slide, please. Okay.
This is the ECG taken on next subsequent days.
Okay. Anjan.
Well, you have an EKG that does not show pre-excitation anymore. You still have very prominent P waves that are upright, but if you just looked at this EKG, you would have said there is no pre-excitation, but I'm assuming you have the EKG from the previous day that shows the pre-excitation. So then the question comes up, what happened? Did the pre-excitation go away and the accessory pathway resolve? Or the more likely scenario is that, remember the AV node and the accessory pathway are always competing with current going down. So the current starts in the sinus node and it can go down either the AV node or the accessory pathway. The more current that goes down the AV node, the less of the pre-excitation you're going to see, and vice versa. So in this particular case, either the heart rate or the adrenaline or something may have been activated in this child, and you're seeing a lot more of the AV nodal conduction, which is masking or concealing the antegrade conduction down the accessory pathway. And there'll be other times that this pre-excitation may show up. So just because I don't see pre-excitation on an EKG doesn't mean that the pre-excitation is not there and concealed.
Anything else you want to add, Carolina, or anybody else?
Yeah, one interesting thing about this ECG is that aside from the right atrial enlargement, it would have been hard to tell that this was an ECG from a patient with Ebstein's. And so in many patients, and the majority of patients with Ebstein's, they'll still have a right bundle branch block pattern when they're not obviously pre-excited. And one of the subtle features that you may see is that when they are pre-excited, that their QRS actually looks narrow. So that's an interesting feature for this patient.
words that we use in electrophysiology is the word fusion. The word fusion means that there are two wavefronts of depolarization which are colliding. So if you, in Wolff-Parkinson-White, most of the ECGs show a fusion between a QRS, the ventricles being activated through the accessory pathway and the activation through the AV node. So you can have, I think this is the point that Dr. Batra was saying, sometimes you can have very wide when if most of the ventricular myocardium is being activated through the accessory pathway and not much through the AV node, to almost none where most of the activation is through the AV node and not much through the accessory pathway. So one of the things we often see in Wolff-Parkinson-White is that this variation in the degree of the width of the QRS complex. Sometimes that I just wanted to point out that word because we sometimes use it very quickly and easily, and others don't understand what that word means. Next slide, please. Okay, go ahead.
Glucose child was extubated and stabilized gradually. Inotopes were tapered, and her saturation improved to 96. Antigrade pulmonary blood flow was achieved, and oral beta blockers was initiated. Initially started on propranolol 3.5 mg OD and then escalated to BD. No further recurrences on the during hospital stay, and child is under follow.
So let's talk about beta blockers in this context. So you've established that this is atrioventricular reentrant tachycardia due to probably a right-sided accessory pathway, etc. What do people think about twice daily and once a daily dosing of propranolol? How much propranolol do you typically use in infants, and how often do you give them? Anybody?
So I typically dose propranolol 3 times daily in infants, just based on the half-life, and a starting dose somewhere between 2.5 and 3 per kilo per day.
What about your maximal dose? How high do you go with propranolol, and what do you worry about when you do propranolol?
Well, I think that, I mean, you can go very high on your propranolol. I think even up to 6 per kilo per day. But I think that as you go that high, your likelihood of efficacy with further dose increases is low. So if I've pushed the propranolol past 4 per kilo per day and I'm not having much effect, I think I would be considering switching agents or changing my antiarrhythmic strategy rather than going much higher. So with propranolol in infants, we have to be cautious of hypoglycemia and as well, of course, of bradycardia or hypotension.
I also typically use at least 3 times a day, sometimes maybe 4 times a day, because of the short half-life in neonates and infants. What about digoxin in this patient? People use digoxin for AVRT patients. Would anybody use digoxin, or we generally say digoxin is contraindicated in Wolff-Parkinson-White? Would you follow that? Carolina, you and Susan are probably the right people to answer this question.
I personally don't use digoxin in the setting of ventricular preexcitation. I know some might in an infant, but I personally don't, as I think we have other agents that we can use.
Just to help the audience understand, why do you not use digoxin in Wolff-Parkinson-White?
The concern with digoxin is that it can accelerate the rate of conduction across your accessory pathway. And so if you were to go into a rapid atrial tachycardia or something like atrial fibrillation, then you may have a faster ventricular response, which could lead to a life-threatening event.
Okay.
And that's the concern with digoxin.
Thank you so much. There's a few questions in the audience, and I will read out all of them. But first, I'm going in a backward direction. Peter, what is the goal of beta blocker therapy? This is a question from Peter to everyone. What is the goal of beta blocker therapy, and do we really think it works in a newborn with a healthy AV node? Maybe, Peter, you might want to answer your own question.
Well, I've never been a big proponent of beta blocker therapy in newborns because the goal is presumably to poison the AV node enough so that it can't participate in tachycardia. But babies have such a strong AV node that it's pretty difficult to poison it enough to keep somebody out of tachycardia. So if your goal is just to reduce somehow or other the incidence of atrial or ventricular ectopy that triggers tachycardia, that may be all that you're getting out of this. But otherwise, I think using it as an agent to poison the AV node, I think you're deluding yourself in this age group.
Any thought?
Yeah, I do think, as you alluded to, that propranolol, one of the goals as well is to decrease ectopy burden, which may then trigger tachycardia as well.
Do I have to say that, just from our own personal experience, beta blockers do make a difference. I don't think we want to take the message over here that beta blockers are not effective in neonates. I think we've tried it. We've looked at studies, and the kids will come in with lots and lots of episodes of SVT. We start them on beta blockers, and those episodes do become less frequent. Now, granted, the point over here is you may need really high doses of the propranolol and beta blockers, and low doses may not work. And there'll be exceptions where some kids may actually increase because of the AV node and refractory periods. But for the most part, beta blockers do work, and I think they should be first line to try even in this population.
I think that's a great point. I think both of you made really good points, which is, I think Peter's point is more about how do we think beta blockers work? What do we think is the mechanism of action, and what are we actually using it for? But I think empirical evidence, I would agree with Anjan, there's a lot of empirical evidence and in the literature, quite decent studies, including Shu's SAMIS study that shows it's pretty efficacious. So now let's go to the other question in the chat, which is, if it is recurrent, in spite of being on beta blockers, what drugs to use, and how long, if there's no recurrence, how long should beta blockers be continued? Rajesh answered that they would use flecainide. And I think somebody else also said flecainide. So let's take with the first question. If there are recurrent episodes in spite of a decent dose of beta blockers, would everybody just opt for flecainide, or are there other options?
I think that's the question on the next slide, isn't it? Where if there's breakthrough options.
Yeah, let's go to the next slide. I think that you're right, Carolina. Sorry, I forgot. The question to the audience. So we'll ask this question of the audience and see what everybody says. And then that may itself answer the question. Okay, Hannah, thank you. Let's show the answers. So most people, the highest was for adding flecainide. Some people would increase the dose of beta blockers, digoxin and sotalol, and no ablation in infancy. Okay, so any one of you maybe take this question, please. Recurrence question.
Right, Carolina.
All right, so I definitely not an ablation in infancy. So an ablation in infancy is really a rescue when you don't have other options, just given the risks of performing an ablation in infancy. So the question really is, how else would we medically manage this? And I think that it depends on some other nuances in terms of the beta blockers. So if you're on a low dose, one of my first steps would be to go up on the beta blocker and see whether or not there's efficacy there. But as we talked about, as you get higher, then I think your proportional increase in efficacy gets lower with your dose of beta blockers. And then in terms of second steps, I don't think we have great evidence for what would be a more efficacious second step. I do like the combination of flecainide and beta blocker, or trying flecainide alone, or sotalol. I think any of those are reasonable options. And in many cases, I try and assess what I think I would be more worried about in terms of toxicity. So if somebody already has a longer QT, I would err away from sotalol. If someone already has a wider QRS where it may be harder to assess for QRS widening, I would may err away from flecainide. Any
choice in terms of other beta blockers other than propranolol. There's a question about whether atenolol or nadolol could be used.
I mean, bottom line, is this is a pediatric patient. Nadolol comes in pills, much higher doses, same for atenolol. So propranolol is the formulary that we have in that we can give, you know, different the concentration. So propranolol becomes the drug of choice.
So it more becomes a matter of what is available in your setup. I think in the United States, propranolol already comes from the pharmacy as a suspension. Nadolol and atenolol and so on has to be what we call compounded. So a pharmacist has to make it up in the correct solution, etc. So there is always room for error when that is done. So that's why propranolol is the preferred option. But in where you are, you might have to look and see what's available and then use accordingly. Well, this has been a great discussion. We've covered a lot of ground, lots of basic points. Please keep making comments and questions in the chat room, but I'm going to ask Dr. Sai Kiran to end his presentation. I think this is the last slide. Am I right, Sai Kiran?
Yeah, yes, sir. This is the last slide.
Okay, and then thank you so much. Fantastic presentation, great case. And then Dr. Batra will be doing our summation today and giving us some take-home points.
Thanks, Balaji. Would you say about 10 minutes? Is that?
Yeah.
Okay.
We typically go till 1 hour and 1 hour 15 minutes. So you got time.
Okay, good. So if I'm going over, let me know, but I'll try to leave some time for questions at the very end as well. So here we go. Question for you guys first is, can you see my screen?
Yes, it's in the presenter mode. So go to the full slideshow mode. So you do the thing
Okay.
that, yeah.
How about now?
Looks great.
Okay, it's good. All right, so here we go. So SVT in Epstein's anomaly, obviously this was a wonderful presentation, and we already covered a lot of the stuff in terms of what I'm going to be talking about, but doesn't hurt to have some repetition. Epstein's anomaly, I think everybody knows what Epstein's is, but it doesn't hurt to review. You have your right atrium, your left atrium, left ventricle, right ventricle, your valve, especially the septal leaflet, is displaced inferiorly. Okay, so you have the sail-like anterior leaflet and the septal leaflet gets displaced. So your annulus is here, right? So keep that in mind. The annulus is you can see my arrow pointing, can you?
No, we're not able to see your arrow.
Okay, sorry, but you guys see that 2.6 centimeter. So the annulus is higher up and at the bottom part is where the septal leaflet is inserting. So that's, and Epstein's can have various degrees of Epstein's, right? You can have severe, you can have very mild, but you can have WPW or SVT associated. It's not the degree of Epstein's malformation that you have that necessarily correlates with your incidence or severity of your WPW. But the one thing I do want to keep in mind over here is in this picture, the RV is really small, right? So when these kids go into SVT, the Epstein's patients, their SVT may not be as well tolerated as a kid with a normal heart who goes into SVT. Most of the times, kids with normal hearts, when they go into SVT, they tolerate it. They just feel the palpitation, the fast heart rate. But in Epstein's, because your RV volumes are so small to begin with, when they go into SVT, their volume that they're pumping antegrade goes really down. And if they're older Epstein's patients, oftentimes they'll come with syncope or much more severe symptoms than a patient who's a non-Epsteinoid patient with SVT. So we'll start off with a question. What percentage of Epstein's anomaly is associated with pre-excitation and Wolff-Parkinson-White syndrome? Less than 10, 20 to 30, 30 to 50, or greater than 50%?
Okay.
So very good. I mean, you guys are right in the center. And majority if you pick 20 to 30%, which is the correct choice. So we can go to the next slide. So this is stuff that's published. I put the references on the bottom, but pre-excitation is associated in 20 to 30% of the times with Epstein's anomaly, WPW. And at least 15% of the patients with Epstein's will have episodes of SVT. So just because you have pre-excitation, remember, doesn't mean you're having episodes of SVT. So how many of them have SVT? So about half of them with pre-excitation will be having episodes of SVT. What is the mechanism of tachycardia? Well, we know that looking at that echo image that I looked at and I showed you guys initially, the right atrium is huge, right? And the RV can also be dilated, or, you know, and you have these, because you have the tricuspid valve shifted below, there is an atrialized right ventricle, and the conduction, think of it this way, the tricuspid valve has fibrous tissue around it, and it prevents conduction from the atrium to the ventricle. So when your tricuspid valve leaflets are shifted inferiorly, all of a sudden you have these potential for pathways there where electricity can go from the atrium to the ventricle now, or at least atrium to the atrialized right ventricle. And they can be multiple pathways, and they can be really broad pathways. So unlike classic WPW without Epstein's, where these pathways are very small, very delicate, you touch them and they go away, these pathways can be broad, they can be multiple, and that's why sometimes they're difficult and challenging to treat, even in the EP lab. Also keep in mind that even though we are talking about AV reentry tachycardia, and that may not be the only arrhythmia in these patients. So think of the right atrium being dilated. As the right atrium becomes dilated and stretched, it is going to be a nidus for atrial flutter. So that you may not see in the newborn period, but if it's an older patient, you may see other arrhythmias, and the incidence of atrial flutter and atrial fibrillation goes up significantly as they get older. And that was sort of shown in the study that looked at a large percentage of Epstein's patients with arrhythmias. It was a surgical patient, but they actually found atrial flutter fib to be even more common than the accessory pathway mediated tachycardia. So 49 patients had accessory pathway mediated tachycardia. 70 of them had atrial flutter fib, but please keep in mind the median age in this patient population was 25. So this is not infants, this is not kids. And as you get older, AVNRT, typically you don't see in the newborn period. It's more, you know, when they start having symptoms after age 5 and teenagers. So again, this is an older population, so that's why they're seeing AVNRT as well. But if it was an infant, I think accessory pathway mediated tachycardia would be the most common arrhythmia. So another question. The most common location for accessory pathway in Epstein anomaly is along the mitral annulus, along the tricuspid annulus, along the tricuspid valve on the septum, and along the pulmonary valve, or along the pulmonary valve. So this is a little bit of a trick question. I think I'm seeing responses. Everybody's picking the tricuspid annulus, which is, or tricuspid valve / tricuspid annulus. Keep in mind, as you guys are putting your responses, the septal leaflet in Epstein's anomaly is displaced inferiorly. Okay, so choice C is along the tricuspid valve on the septum, which means it's lowered down, and the tricuspid annulus is higher. Okay, so right now I got a 50-50 response, and the correct choice, the correct answer in this is choice B along the tricuspid annulus. Okay, and I'll tell you what, there's the next slide, actually not the next slide, but one of the slide after this is going to be coming up with a picture of it, and I'll kind of go over that in a little bit more detail. But I already talked about they can have multiple pathways, they can have very broad pathways, and they don't tolerate this as well as the patient with normal anatomy. So these patients can be a lot more symptomatic and hemodynamically unstable as opposed to somebody with a normal heart. So this is a picture I promised you I'll tell you about to explain that answer a little bit. So if you look at the RAO view, the anatomy, the left side is a cat, like a fluoroscopy picture, and the right side is a drawing. So let me focus on the right side of what you have. You start off with the right atrium, then you see the circle where the tricuspid annulus is, and then you see the atrialized portion of the right ventricle, and in the bottom where the annulus, the septal leaflet is inserting is the lower line, right? So the difference between the tricuspid annulus and where the tricuspid valve inserts, the inferior insertion, which is on the septum, is the atrialized portion of the right ventricle. These pathways are on top where the original location of the tricuspid valve should have been. So even though the valve is displaced inferiorly, the pathways are higher up where the tricuspid annulus is. So hopefully that helps you answer that question better now, that it's not where the septal leaflet is attaching on the septum, but higher up where the annulus is. Management, well, I think we've gotten pretty good at radiofrequency ablation. At least electrophysiologists can agree on that. Even though these are broader pathways, multiple pathways, that would still be a first line of treatment management at an older age, not in an infant. When they are reached, 3 to 4 years of age, they are over 15 kilos. That's sort of the cutoff that we use. And so we would still do ablation or EP study / ablation. Now, one of the things that we are doing as a protocol, and that's based on the next slide, the study that was done, actually not this one, but I'll get to that as my last slide, is if they're going for surgery, if they are going for a tricuspid valve repair, then we will take them to the EP lab, even at a younger age, not so much to ablate, but to map that pathway. So the surgeon, when they are in there and they are repairing that tricuspid valve, may be able to try and address that accessory pathway at the same time. So there'll be an opportunity for the surgeon to do that. So we have actually made it as a protocol between our institution and UCLA that if somebody's going for an Epstein's valve repair, we do an EP study on them irrespective of their age, even in the first year of life. So we could do a quick EP study. So this was actually talked about a little bit on the presentation between narrow complex and wide complex tachycardia, antidromic and orthodromic tachycardia, and what the QRS morphology looks like when you're having tachycardia. So there is A and B. I hope you guys can orient yourself. So A, EK 1280 EKG is on top and B is on the bottom. If you look at A on top, it is narrow complex tachycardia. If you look at B on the bottom, it is a wide complex tachycardia. So this is a great example of a patient with Epstein's, and you can have both in the same patient. You can have a narrow complex tachycardia and a wide complex tachycardia. The narrow complex tachycardia is the orthodromic or the normal tachycardia, like Carolina mentioned, where you have it going down the AV node and up the accessory pathway, right? So conduction is going down the normal AV node, so you're going to have a narrow complex. And the retrograde going up the accessory pathway, you'll see P waves after the QRS to show you that the P waves are negative, as you can see on in A. In B, you have a wide complex tachycardia. So this could be an example of an antidromic tachycardia where conduction goes down the accessory pathway. So if it's going down the accessory pathway on the right side, right, you're going to see a left bundle branch block. So if you look at this in lead B1, you see a left bundle branch block. And if you look at lead AVR and AVL, it's negative in AVR, means it's going away from right, and it's positive in AVL, means it's coming towards the left. So it's right side to left side, example of an antidromic tachycardia. Now, you could, in the differential, it could still be an orthodromic with a bundle branch block, but don't worry about that. More importantly, I want you to know that orthodromic and antidromic, what the EKGs would look like, and you can have the same in the same patient. You can have both, in the same patient. And this is just another example of WPW. We've seen this both, the first one is pre-ablation. So you can see the short PR and a delta wave, a wide QRS, the 3 hallmarks of WPW. And then once you take them to the EP lab and be ablated, you can see the separation between the P and the QRS, your lead 2 being the best. You see a change in your QRS. We talked about the QRS morphology, how it's gone now from negative in lead 2, your QRS, to upright in lead 2. So it's no longer going down the accessory pathway. It's now going all down the AV node, and that pathway is gone. The conduction down the accessory pathway is gone. And this was the last slide that I have that I promised you. We'll talk about, just a reference of the surgical paper that recommended doing EP studies in all patients who are undergoing tricuspid valve repair. I mean, I think you have to kind of use your judgment. Obviously, if the baby's too small or there's too much of a risk, you don't have to. But if you do it, I think you can base that judgment on this study. And we have started doing that more. So that's just our institutional practice. I'm not sure if every institution is doing that or how they're doing that, and that you guys can chime in at this point. Balaji, Susan, Tony. Tony's actually at my institution. So, but anyone else, Carolina. So I'll stop over here and see if there are any questions.
Thanks, Sanjan. Actually, there were a couple of questions in the chat, which you probably have already answered, but you can re-emphasize. First question is, should we treat or ablate accessory pathways in Epstein's, even if they have no episodes of SVT? Because if they develop atrial fibrillation, it can conduct faster down to the ventricle.
Well, I'll go one step backward and I'll say, even if you don't have Epstein's and you have pre-excitation, you go ahead and take them to the EP lab. And that paper, there was a very nice paper that was, a consensus statement from the Heart Rhythm Society and the PACES that said the answer is yes. Because even though you have pre-excitation, you can be at risk of sudden death and you can be at risk of having SVT, even though you've never had an episode. And EP studies have become so effective and so safe that you would take them to the EP lab. And if you find a pathway or a dangerous pathway, you ablate it. In Epstein's, all the more reason, because these patients don't tolerate SVT very well. So yes, the short answer is yes, I would.
I'm going to ask Carolina to weigh in because she wrote the paper on that.
All right, Carolina.
I think, as you mentioned, especially for preoperatively, we do want to assess whether or not there are these accessory pathways, and we do that as well at our institution. So push-cone procedure would assess for an accessory pathway. And so in that scenario, certainly I think that doing an accessory pathway ablation is very reasonable. Otherwise, I think that we would still assess for these patients to see whether or not they had high-risk features of their accessory pathways. And if we were worried about them developing a life-threatening event, then I think that that ablation would be reasonable.
So last three things I want to ask. One, or I want to say and ask. One, at what age should such an EP study be done?
So I think if you are going down the route for a preoperative assessment, then you may, of course, have to adjust your age depending on when it's felt the patient needs to have a procedure performed. Otherwise, I prefer for children to be a little bit larger, but we know that the risk for ablation in children with structurally normal hearts is lower when they're more than 15 kilos. So some people will use that as a cutoff, but I would say early childhood is a reasonable age to do this.
Then there was a question from Varun. I think, Varun, your question's already been answered. Yes, ablation should be done prior to cone repair. And last point, Hannah has put out the survey for today's program. Please take a moment to fill it out. She will also be emailing the survey. Thank you to everyone who fills out the survey. I encourage all of you to do it. It really helps us a lot in terms of planning and in terms of refining this program. So we are a little bit over time today. This has been a great program. I want to thank everybody, particularly the audience, for being here and for asking all the questions and comments on the chat feature. Okay, last question. How about ablation before neonatal cone repair? I think Anjan already answered this question, but I'm going to ask him to answer it one more time, and that'll be the end of it.
Yeah, I mean, I think doing an EP study is reasonable. Generally, the reason for the EP study is to map it out so the surgeon can address that if they're going for a cone repair. Now, if you ask me if you were there and we found something like really obvious, we would try it. And at the very least, you can make an argument that now you've marked the location for the surgeon, even if you don't have success, because they can see where we ablate. And then they can do more deeper lesions in the operating room at that time. You're muted, Balaji.
don't know how that happened, but anyway, thank you, everybody. This has been a great program. Last announcement: the December program is also going to be 1 week early because of Christmas. So I think it's December 17th. Friday is going to be the program. It's going to be another very interesting case. We are currently preparing that program. And so for those in the United States, have a great Thanksgiving. For everybody else, have a great weekend. Thank you all for coming. Bye-bye.